So, as I mentioned, I am a public health dentist. I graduated from the University of California, San Francisco back in 1994. I went on to be an assistant clinical professor for our community clinics, public health, postgraduate work. I was the chief for the Office of Oral Health for Maricopa County's Public Health Department. And prior to becoming a dentist, I was a registered dental assistant. So I've been in dentistry since 1981. How many years is that? 45 years? More than I care to count. I never, ever in my entire life would have considered that I would have become infected with Clostridium difficile. But I did. And actually, it was 4 years ago today that I was diagnosed. So it's sort of a new sort of birthday for me. I'm hoping today my life was spared. You're going to hear my story. And I've been working with Dr. Tom Palmier, who is the co-author of the guidelines for antibiotic prescribing with the American Dental Association. He was just elected as president-elect to the ADA as well. This has been something we've worked on for 4 years to try to reach all of you, because my story, unfortunately, is not that out of the norm. And the only thing that was different about me is that I'm a researcher, and I knew to find where I could find, hopefully, the information to save my life. Had I not had that information, I can tell you definitively I would not be here today. If I would have relied on my dental school education, I would not be here today. And I've heard this from multiple experts. So welcome to a very sobering, but hopefully uplifting course today, that you can take this information back to your practices because it's really, really needed. There's my conflict of interest and financial disclosure. And the Dental Antibiotic Stewardship Program is a program that Dr. Palmier launched last year at my behest. I said, you need to become an antibiotic steward for all of these dental clinicians out there that really don't have that sort of backup like the hospitals do and other institutions. And so he's launched this. Please be sure to check it out. He offers quite a bit of information on there that will help you in your practice and maybe save a few lives as well. Again, to receive CE credit, this link is in your handout, so I do want to make sure that you have it. And I would recommend that you follow along this morning. That passcode is at the end of my presentation. It will be on the screen, and I will announce it verbally. So I'm going to put a survey up on the screen, and I'd appreciate you all completing it for me because it's going to give me a little idea, quite a bit of an idea of where you all are in your knowledge base in terms of C. difficile. It's on the screen right now, and we have, 5 questions here. So the first one is for prescribers only. It is anonymous to dentists. Have you had a patient develop Clostridium difficile infection following an antibiotic you prescribed? No judgment there. Number 2, for dental prescribers, yes or no. I recommend probiotics to my patients. Number 3, for all attendees. Do you currently use disinfectants that kill Clostridium difficile spores in your dental practice? And number 4, Clostridium difficile is an opportunistic infection due to the overgrowth of pathogenic bacteria in the gut. And number 5, prescribers only. I currently prescribe clindamycin to my penallergic patients. Again, there's no judgment here, no admonishment. This just gives me an idea of where I may need to focus a little bit more. And again, your answers are anonymous. I did forget to mention that this is a very large class today, so the chat area is monitored and moderated, which means if you post something, I can see it, but nobody else can. So we're going to keep it that way today until we have Q&A, and then questions that we see, we will go ahead and share it on the public side. Okay, we're going to leave this up for just a minute here. Please jump on. We're at about 51%. All right, 30 more seconds. We're at 56%. So we need a few of you to hop on here, please. Let's get this up to as 100% as possible. This is part of your live interactive credit, so make sure that you get in there and answer that for us. Okay, we're going to go ahead and shut it down. All right, so the question, first one, please respond if you're a prescriber. Have you had a patient develop a Clostridium difficile infection following an antibiotic that you prescribed? 13 of you have answered yes. 96% of you no, and 26% I am not sure. All valid answers. We do not track Clostridium difficile infections. They are not tracked in outpatient settings yet. So unless the patient definitively let you know, you would not know, number one. And number two, I am not sure is a valid answer, again, because there's really no authority that's going to contact you like the public health department. If you were a hospital setting or a nursing home setting, that would be a different story. Those tables are about to change. The pharmacies now have been tracking on behalf of Medicare and insurance entities the patients that are being prescribed specific medications for C. difficile. And they're going in and they're looking at the prescribers that prescribe the antibiotics. Why? Because it's a very expensive infection to treat, as you'll see here shortly. And in hospitals and nursing homes, these institutions are fined heavily for these infections. They are penalized. So they're getting their act together because it's a monetary issue for them and a liability issue. But for we in the outpatient world, like dental practices, up until this point, there has not been a real way to track these cases, but that is about to change, which is the other reason why we want to make sure we get this information out to you. Number two, for dental prescribers, yes or no, I recommend probiotics to my patients to help reduce the possibility of adverse reactions from antibiotics I've prescribed. And this is about 50-50, a few more yes than no. Now, I've been presenting a course on probiotics since 2014. So I took probiotics for the majority of my adult life, and I've taught microbiology at the university level. So I really thought if anyone was going to be prepared not to get a C. difficile infection, it would have been me. And that's anecdotal. But the American Dental Association on their website actually states that they do not recommend that clinicians use probiotics to prevent Clostridium difficile infections or recommend them to their patients for such. Why? They cite a study by the Infectious Diseases Society of America, where they believe, according to their study, that they simply have no scientific basis. Um, Probiotics are not FDA regulated. There is no probiotic on the market that is FDA approved. They are all considered supplements like vitamins. So we'll talk about that in a little bit more detail. So there's quite a bit of division about probiotics. Do they work? Do they prevent C. diff? Can you use them to treat C. diff? Okay, number 3, for all attendees, do you currently use disinfectants to kill Clostridium difficile spores in your dental practice? We have 26% of you that have answered yes, 4% no, 31% unsure. So in the US, we know probably 95% of dental practices are not using disinfectants that kill Clostridium difficile spores. You may believe you are because you're looking at a label that tells you perhaps it's tuberculocidal, so there's a lot of confusion with that claim, but also a brand out there, Cavicide or Cavawipes, which are quaternary ammonium compounds, and they're very good at what they're supposed to do, but they do not kill C. difficile spores. If you read the label, it will state that it kills Clostridium difficile, but that's in its vegetative state, which is anaerobic, and it's going to die on your countertop in a couple of hours. It's the spores that we need to be very concerned about, and we'll talk about that today as well. So the majority of you are probably not using a disinfectant that kills C. difficile spores, or what is called sporicidal. And you would find that on EPA List K. So again, we'll talk about that in a little bit more detail coming up here. Number 4, Clostridium difficile is an opportunistic infection due to the overgrowth of pathogenic bacteria in the gut. So about 45% of you have answered true, 4% false, and 11% I am not sure. So when we think of an opportunistic infection, one that comes to mind is yeast, right? Candida. If a patient takes something to reduce their immune response, they may develop a Candida, or what we call thrush infection, right? That's opportunistic. The yeast living on our body, within our body, and when the gut microbiome or the biome of the skin or the oral cavity becomes disrupted, it creates a niche for these bacteria or yeast that are usually displaced for resources to take over, proliferate, replicate, duplicate, whatever the case may be. And it can become an infection, right? Now, in the case of C. difficile, Clostridium difficile is not supposed to be living inside of us, but there may be a few that are colonized with C. difficile. We call those carriers. Okay, so between 0.4 and 15%, as we'll see, of the general population actually are carriers of C. difficile. 15% would be someone like me that's had a known prior infection, or in my case, multiple infections. The majority of these cases are transmitted from healthcare practices, meaning healthcare practices are contaminated with the spores. So when we prescribe an antibiotic and we invite the patient back to complete an endodontic procedure or a post-operative check, we are inviting them back into a contaminated environment. Now, hospitals know this. Medical clinics know this. Kidney dialysis clinics know this. Dentistry, a little bit behind the times here. In fact, if you do a search on C. difficile in dentistry, you'll see a couple of arguably the worst articles ever written about C. difficile contamination in dental clinics, because they are so completely wrong. And they state, well, it's impossible to transmit C. difficile in a dental practice because it's spread through feces. Well, patients may not wash their hands. We'll see spores are everywhere in the natural environment, but they're in much greater levels in dental and other medical practices. So we'll talk about that today. And that was a real eye-opener for me. Even as a public health dentist, I was unaware of that. For prescribers only, I currently prescribe clindamycin to my penallergic patients. This is usually 50-50 or a little bit more in the yes range. So um, very close, 44% of you answered yes, 41% no. The American Dental Association no longer recommends clindamycin for the purposes of antibiotic prophylaxis or initial infection. They were removed from the guidelines actually twice, once for um, infective endocarditis and then another time for prosthetic joint replacement. So we'll talk about that as well and give you some resources. Okay, so that is our survey. We certainly have a lot to talk about today. So here are our learning objectives. We'll discuss the pathogenesis, clinical features, and current trends in virulence and prevalence of C. difficile infection, identify populations at increased risk for C. difficile infection, describe ways that Clostridium difficile bacteria can be transmitted, and apply key principles, and develop a specific strategy for infection control and prevention of C. difficile infection within the dental practice. This includes administrative controls, environmental cleaning, and antimicrobial stewardship. So this is my new hashtag, not one that I'm particularly crazy about C. diff survivor. I became a national speaker on Clostridium difficile after I survived this infection 4 years ago. And let me tell you how that happened. So in January of 2022, I underwent periodontal surgery. I fractured number 3, vertical root fracture. It was a ceramic crown, endo treated multiple times, no infection present. Implant was to be placed later. And as an aside, this is just an interesting factoid. I was working as a registered dental assistant for a prior president of the ADA. She was not the president at the time, and she and I actually did a trade. So she had placed the first crown on that tooth that was not the crown that failed. I ended up with some vanity getting an all ceramic crown, and um, that's where my downfall was. I'm a heavy Brexer, so I fractured that right in half, and there was no infection present. I wanted an implant, so I was referred to a periodontist. Now, the periodontist agreed with me, and we decided that that tooth would be extracted, and I would come back several months later, return to the practice, be evaluated for an implant, and so forth. So prior to the procedure, I was prescribed clindamycin. I'm penallergic, 150 milligrams 3 times a day for 6 days, beginning 1 day prior to the procedure, 5 days following. I had no post-operative complications, healed as expected. I returned to the practice a couple of times for a follow-up appointment just to check. And at the 30-month follow-up, I was told everything looked great. I had been on a soft food diet for a month, so I could return to a normal diet. I was super excited about that and returned home. Now, I did ask the periodontist about the clindamycin prescription because I had not had antibiotics for at least 12 years. And I wasn't crazy about taking antibiotics, and I certainly wasn't crazy about taking clindamycin. But he assured me they had excellent results. He had been practicing for 40 years, and it was to prevent infection later. I didn't argue with that, and I did what I was told. It's hard to sometimes be a good patient when you're a clinician, right? You're going to try to second guess things. I do. But I decided this time, hey, I'm going to put myself in this clinician's hands. He knows what he's doing, and I just have to trust the process. So after that 1 month follow-up, and let me back up the tape here. So when I picked up the prescription for clindamycin, the pharmacist came out for the consult, and he knew me. He said, "Hey, Dr. Rolling, You know clindamycin, you know the black box warning and the risk. He said, but we don't worry about someone like you. You're not an elderly person in the hospital or in a nursing home. This isn't IV clindamycin, it's capsules, you'll be fine. So this was the second provider telling me I was going to be fine. Now, after my 30-day follow-up appointment, within 48 hours, I developed severe gastrointestinal symptoms. It started as full-on bleeding. I was defecating blood. There was no diarrhea involved at first. I had some stomach cramping and bleeding, and I was scared to death. And C. difficile did not enter my mind right away. I was worried it was something like colorectal cancer. So I was evaluated by urgent care on day 2, and they diagnosed me with irritable bowel syndrome. And they prescribed an antidiarrheal. And their rationale was, well, you were on the soft food diet for a month, and probably when you started eating solid food, this IBS kicked in. Well, I didn't have a history of IBS, and I didn't trust that diagnosis. So I got online and I researched C. difficile because that was in the back of my mind. Now, when I was trained at UCSF, I understood that patients that develop C. difficile developed these symptoms while they were taking the antibiotic, or maybe within a few days of the antibiotic. But this was a full 30 days later. And to my shock and horror, I saw that you could develop a Clostridium difficile infection up to 3 months, 90 days after you finish that antibiotic. Now I was really terrified, right? So I was evaluated again by urgent care. Now they prescribed an antidiarrheal. And fortunately for me, because I had researched on Dr. Google first, and I saw all of these cases of people dying from C. difficile that had taken an antidiarrheal because they had been misdiagnosed, I told myself, nope, I'm not taking an antidiarrheal until I have a definitive diagnosis. So I had an appointment waiting for me in gastroenterology, but this was the pandemic, and it was going to take me about a 9-day wait to get in. The following day, my symptoms subsided a little bit, and I thought, okay, you know what? Maybe this is a weird IBS thing I've never had. But the following day, those symptoms came back with a vengeance, and I was spiking a fever. I was in sinus tachycardia. I was dehydrated, and I was evaluated by urgent care again. Again, they told me it was IBS. They administered IV fluids, and they again prescribed an antidiarrheal, and they admonished me. They said, look, you need to take the antidiarrheal or you're just going to have to keep coming back here until your gastroenterology appointment. But I didn't take it because, again, I was not confident about the diagnosis. And both times I asked the doctor, do you think this is C. difficile infection? Because I took a clindamycin prescription for a dental procedure about a month ago. And the first doctor told me, you would know it if it was C. difficile. I don't know what that means. And the second doctor just shook his head at me and kept entering the notes in his laptop and said, just keep your appointment with gastroenterology. It's IBS. So by about day 9, day 7, day 9, I had the gastroenterology appointment. At this point, I was so weak, I could barely walk. And I called them and I said, I don't think I'm going to be able to make it physically to this appointment. I think I need to go straight to the hospital. And the nurse that answered the phone said, look, if you can get in an Uber, we're 15 minutes away. And if we think we need to admit you, our parking lot adjoins the emergency department. And I can remember saying to myself, how did I get here? A week ago, I was perfectly fine. And today I can hardly walk. And I got in an Uber wearing a diaper because I was completely incontinent. I was having no control of my bowels whatsoever. So made it to the gastroenterology appointment and gave my chief complaint, diarrhea all the time, took clindamycin a month ago. And finally, he looked at me, and he had a resident in the room with him from the University of Arizona. his name was Dr. Singh, and he threw his arms up in the air. He said, Kirsten, he knew I was a public health dentist. He looked at me and he said, what do you think this is? I said, Dr. Singh, I'm really worried it's C. difficile. He said, it is. It is C. difficile. We have to get you tested right away. And he said, for God's sakes, do not take those antidiarrheals that you were prescribed because it can cause a condition called toxic megacolon. And honestly, again, if I had not read that, I would have taken those antidiarrheals. I've been told by infectious diseases experts, I would not be here today had I taken those antidiarrheals. I would not have survived this infection. So they ordered some tests, and you'll see my lab results here. Now, I just want you to see what's tested for C. difficile. So first of all, they're going to test, it's a PCR test. They're going to look to see if it's producing toxins. So again, you can have a percentage of the population colonized with C. difficile, and they'll test positive as having the infection, not the infection, but having the bacteria, present in their colon, but they don't have an active infection. Okay, so how do they tell if you're actively infected? Well, first of all, they see, is it producing toxins? And in my case, that was the case. So it was toxin B. Here it is. And they check for inflammatory markers. So if there's a acute colitis, there is an enzyme basically that is checked for in some of these laboratory results. So it's called calprotectin. And the normal range here is 49, less than or equal to 49. I was at 753. Very, very, very ill. Now, fecal globin by immunochemistry, they also want to rule out the possibility of colon cancer. So that's what you're looking at here, and then fecal lactoferrin. So these are the results that can give them a definitive diagnosis. So they don't just check to see if Clostridium difficile is present. All right, so after that initial infection, the gastroenterologist told me that it was not that common to get recurrent infections, but that's not what I read. I saw there was actually a 30% risk factor for me to get a second infection. I wasn't wishing that on myself, but again, I'm just a pragmatist. I looked at this and I said, hey, these odds are not good. After that initial infection, I had 3 recurrent infections. I was admitted to the hospital 4 times, twice by ambulance. I had 4 urgent care visits to my home to put an IV in my arm. So the gastroenterologist would send these urgent care folks with IVs to give me IV fluids and make me feel a lot better. But you're put on a clear liquid diet for some time, colon rest, to try to recover from acute colitis caused by the toxins. And you can't get enough protein on a clear liquid diet. So having that many infections, I was always, I never got to the point of really being able to eat anything for months and months and months. Within the first 10 weeks, I had lost 30 pounds. And for the first time in my life, I was staring death in the door. I realized that there's a very strong possibility I might not survive this infection. One of those visits, I was on sepsis watch, and it was scary. Now, I failed the oral vancomycin that was prescribed. It's called Furvank, and it's a liquid medication that you take 4 times a day. So you're getting up in the middle of the night every night. It didn't work. So after the first 10 days of oral vancomycin, I was retested and I was negative for C. difficile. And I was like, great, good, let's get on with life here. And then 2 weeks later, it came back. And I was put on oral vancomycin that time for a month. And after the month, I was tested again negative. And a week later, it came back. Put on oral vancomycin a 3rd time. And this time I was on what was called a tapered dose Well, it was on a dose where they would put you on a high dose, then a low dose, and a high dose, and a low dose. Um, that went on for a month. I tested negative, and within 4 or 5 days, it came back again. Now I'm on the fifth infection, basically. And this time they prescribed an antibiotic called difficile, which is fidaxomicin. It is now the top tier antibiotic to prescribe. And by the way, you're fighting this infection with more antibiotics, right? Difficile is different because difficile was specific for C. difficile in the large colon. So the problem with all of these medications, number one, is you need them to save your life, even if they're not working, but you're hoping they will. But they're very, very expensive. And in my insurance plan would not accept Furvank. They wanted me to take the capsules of vancomycin. And I thought, you know what? I don't want to mess with this. I'm going to do what these experts were telling me to do. So it was all out of pocket. So every round of Furvank, the bottle was about $300 for a 10-day course. But when I got to difficile, that prescription was $5,600 for 10 days. And the insurance company approved it, but they applied it to my advanced tier or specialty tier medications, which had a $6,000 deductible. So it was out of pocket for me. And $5,600 paying for medication, but they told me it was going to make me better. And I tell folks, if they would have told me to crawl on my knees and eat a bucket of dirt and pay $5,600, I would have done it if I could have afforded it. So I did it, and I took it for 10 days. It was twice a day. And they had their rep call me and say, this is great medication and blah, blah, blah. After 10 days, I tested negative, and 2 days later, the infection came back. I'm back in the hospital. And at this point, I can't even tell you the lowest level of low I had hit. I can't even explain it to you. I was so weak. I was so depressed. I contacted my attorney to get my affairs in order. And I started to do some more research. I had heard of fecal transplant when I was presenting the probiotics course. And I kind of mentioned it, but I never really did the research on it. And lo and behold, there I found a colorectal surgeon in Scottsdale, where I live, who was performing these procedures, and he was able to do it during the pandemic. He was the very first physician in Maricopa County who had had the entire hospital system approved to perform these procedures. Prior to that, it was only Children's Hospital, which was really telling because children get C. difficile. So it's a life-saving measure. He entered me into a clinical trial, and the way to be approved for that clinical trial was that you had to be knocking on death's door. And that certainly was me. So the donor was through Open Biome, and they took me into endoscopy at Dignity Health in Scottsdale. It was an outpatient procedure under deep sedation. And within 24 hours, I was completely cured. Now, I can't say I was completely restored, but I was cured of this infection. And I knew I was cured because when I got up in the morning, there was a whole different outlook. It felt like everything lifted. I can't even explain it to you. I didn't feel sick anymore. Even my mental health outlook was better because understand your microbiome is connected to your brain in terms of communication, in terms of your emotional health, and many, many things, your immune system, etc. So when you have that wiped out, it doesn't just affect your gut anymore. So I wrote this. I started teaching this course 8 weeks after I had that procedure. And I wrote this: I'm cautiously feeling hope again that I'm successfully treated. I'm regaining the weight. I'm eating real food that I've slowly entered back into my diet. I'm avoiding lactose and gluten for now, and that's because I was told. What were my post-operative instructions after that procedure? For those of us that were complaining about the pandemic and social isolation, I had another 2 years after this of real social isolation. I was told not to eat restaurant foods, not even to have Starbucks coffee, because if I picked up some sort of norovirus or E. coli or whatever, it could kill me. So be very careful with food. Watch for gut disruptors in your diet. Stay away from some of these chemicals that are known gut disruptors. So I was very cautious. I couldn't travel. I missed a couple of reunions. I missed my daughter's wedding. It went on and on. I had to be very careful not to get COVID. You'll hear my story though. So I want to let you all know that in dental school, and I remember the lecture like it was yesterday in pharmacology, that many of our patients that get C. difficile, we felt, okay, this was a serious matter. But if they're given metronidazole, and maybe they'll require a hospital stay, it's treatable. Not in the least. I mean, this is a very frightening, isolating disease. It leaves you wasted, it kicks you to the ground, and once you think you cannot take any more of having the rug pulled out from under you, recurrent infections, which are very common, it kicks you to the ground one more time just to let you know who's boss. I don't know where I got the strength to even try to research how to save my life. I don't know how I did it. I had given up. So my recovery continues to be in progress. My diet continues to be very limited. I will be monitored for the rest of my life because of the fecal transplant. And the total that was billed to my insurance for a simple extraction of number 3 was $86,000. So this is a timeline, and I want you to note this is February 13th, 2022. So I apparently became symptomatic the 15th of February. So that was 4 years ago. This was my 4th hospital admission, April of 2022. And every time I came through the emergency department, I was admitted upstairs, and it was always for fluids and more medication, and really to check that I wasn't having sepsis or leaning towards sepsis. So they would check neutrophils and other enzymes that are important. And a couple of times I was put on sepsis watch because I was leaning that way, and I was in the hospital for a couple of days. It was scary. The last photo here that you see is me weighing 92 pounds. And this was the day after the fecal transplant. I was so scared to get any infection that I was eating my food on containers. I tell you, all my clothes were white because everything had to be bleached. And I'm not a germaphobe. When I entered the clinical trial, I had to have my house mitigated for any contamination so I wouldn't reinfect myself. So as I tell you more about this story, this is a very serious infection. And this is me, again, sharing this with all of you. This is my payback. I had my life spared. As we're going to see, 30,000 a year don't. So I feel like I was lucky. I was lucky that I had the wherewithal to be able to research this and get myself through this thing. So I'm going to share your questions in the public chat area here in just a moment. And let's talk about what this C. difficile infection is. So again, my recovery is still in progress. I ended up with long COVID in 2024. I was back in the hospital for severe vertigo. Just hit me one day like a ton of bricks, and it turned out it was nothing, but they kept me overnight. And when I had C. difficile, every time I went to the hospital, I was in a room by myself because you're in isolation. They don't want you to contaminate anyone. In fact, when they did the fecal transplant, I was the last one on the schedule that day because they bring in the robots afterwards to mitigate for the C. difficile spore. So it's quite different. But I was apparently, while I was in the hospital, exposed to COVID. They called me and I did get COVID. And I had COVID for about 8 months. I tested positive for 8 months, long COVID. Now, fortunately, I didn't develop any secondary infection like pneumonia or bronchitis or anything like that, but it was crazy. So, when you have a fecal transplant, you don't know who you're getting, right? I'm hoping it was a 20-year-old beautiful person with a great brain that will last me longer than my years now. But beggars can't be choosers, right? So I did have long COVID. I recovered from that in 2024. Last May, I was at our family homestead in Pennsylvania. We had a tornado that ripped through, and it caught. And if you're from Pittsburgh, you know the storm I'm talking about, the end of April. We didn't have utilities for 12 days. So we had to bring food in, and I'm very careful about eating any restaurant food. I try not to, actually. We had no choice. And for whatever reason, everybody at the table was fine except me. I ended up with food poisoning. It was salmonella. So I ended up hospitalized at UPMC in Pittsburgh. And the doctors said, look, with your history, we can't give you antibiotics, but we are seeing some enzymes that tell us that you may be, your body may be thinking about sepsis here. You're pre-sepsis. We're keeping you in the hospital for a couple of days to monitor you. So that was kind of scary. But I can tell you, I beat salmonella without antibiotics. And they told me, the doctors, that many times we reach for these antibiotics when the immune system will actually take care of it, right? And that's part of the problem here. I'm still on a very restricted diet. I do stay away from gut disruptors. And we have a colleague on this platform, Dr. Jennifer Eisenhuth, who is the creator of Dr. Jen's toothpaste. And this is not to be an endorsement. The reason why she created that toothpaste was that her own daughter, at the age of 21, had a root canal, prescribed amoxicillin, and developed C. difficile and ended up at the Mayo Clinic, one of the youngest C. diff patients there, and was told the same thing: stay away from gut disruptors, so forth. So I don't use, anything with SLS. Dr. Jen created the toothpaste in her kitchen for her daughter, and that was how she became a toothpaste maker. She's an orthodontist. All right, so let's talk about C. difficile. Enough of my story. What is it? Transmission, pathophysiology, prevalence, and risk factors. And I hope that I'll change your mindset a little bit, because as I said, at UCSF, we were told patient gets these symptoms while they're taking the antibiotics. Now, granted, this was a while ago, but had I not researched on my own, had I not said to myself, hey, I'm going to wait for a definitive diagnosis before I take any antidiarrheal, again, I would not be here today. So before we move forward, I'm going to show a quick video, because we're going to see that transmission is not just about antibiotics, but it's also about your infection control protocols. And the video that I'm going to show you, these are several experts in the realm of gastroenterology, infectious diseases, certainly C. difficile, certainly fecal transplant. And you're going to hear them talk about how C. difficile is transmitted in the healthcare environment and they are going to call out dental practices and the fact that you can take this contamination home with you. If you cannot hear the video, just log out, log back in. For those of you on phones, hopefully you have the app and you should be able to hear this.
So let's talk about community C. diff if we could for a moment. Uh, what are the risk factors in the community, and how do they differ in the community versus the hospital-based population here? Dale, you want to start us on that?
Yeah, that's a really good question, because there's two factors that we need to have in order to get C. diff. One is antibiotic use, and the other is exposure to the spores. So the spores are ubiquitous. They're out in the environment. They even contaminate at a very low level some foods, meats, root vegetables, lettuce, and those are probably how patients in the community get exposed. They, on the other hand, when the CDC has looked at community-associated C. diff, they found that about 80% of these patients have had an exposure to healthcare as an outpatient. So it's doctor's office, dental office, and chronic dialysis units, ambulatory surgery. And this is where you have two risks. One is that somebody's going to give you an antibiotic, and those are called doctors. And,
we hope it's only doctors.
They put people at risk of C. diff. And the other exposure is that the healthcare environment is more contaminated with C. diff spores than is the environment outside of healthcare.
And I think it's worth noting, Paul is nodding his head. He does a lot of nodding. It's not just the people who are in the healthcare system. It's not just the people who got the antibiotics. They go home. They've got spores, and then their families are exposed. So it seems to me that that's part of the issue, isn't it?
And those spores can live for a significant period of time on many different surfaces, even when exposed to sunlight. And you'll see some data that says alcohol in certain products can kill the spores, but that it really has to be used properly, where the liquid sits on a surface for a significant period of time to have its effects. So the fact that the spores can be taken home with you on your lab coat and in your house and on surfaces for 6 months or a year or longer certainly put people at risk.
Okay, any questions about the video? So that changes really the dynamics of how we thought C. difficile occurred, right? I always referred to the carrier model. The patient was already colonized with it, but we're going to look at the statistics, and actually more patients become infected because they've had contact with a healthcare setting. We see that hospitals and nursing homes, these transmissions have declined. Why? As I stated, they're penalized, they're fined, there's liability there. There are lawyers circling the wagons of these facilities just waiting for a C. diff outbreak. But in outpatient settings, these cases are on the rise. And we'll look at those statistics here. So Clostridium difficile is an anaerobe. Again, it's not going to live very long in the presence of oxygen. It's gram-positive. It's a bacillus. It's rod-shaped. It forms spores. Spores are like a cocoon, and they can live for months to years, as you heard, on surfaces, flooring, countertops, carpeting, etc. They produce toxins. You saw my lab results, transmitted by the oral to fecal route, but oftentimes through cross-contamination, dirty hands, bottoms of shoes, wheelchairs. Spores are found everywhere in the natural environment, the soil, the seawater, the rivers, the air. I was hoping that they would just die off in the desert. They do not. When I was approved for the clinical trial, I was told I had to wipe my entire house down, my vehicle, my offices for Dental C Academy with bleach products. I weighed 92 pounds at the time. I could barely stand up and walk. I wasn't going to be able to do that. So we hired a biohazard team, the kind that come out in murder scenes. They also do C. diff mitigation, apparently. And they came out and mitigated our home and so forth. And what did they use? They used hypochlorous acid. So I'll talk to you about that today. Why? Because the researchers did not want me to go through this clinical trial and reinfect myself with the spores, or my family that live with me, or even my dogs. Animals get C. difficile and vice versa. And veterinarians know this. Veterinarians are at risk for C. difficile. So C. difficile is found everywhere, and this is just a study that shows the bottoms of the shoes are important. It's not recommended that you wear your shoes in your home or that you wear your work shoes home and vice versa. I recommend leaving work shoes at home. Shoe covers are best. If you are going to leave, put your shoes in a bag. Don't take them in your house. Don't let them be rolling around in your car. So there are two phases of a C. difficile infection: the vegetative form. This is the form associated with the symptoms, the diarrhea, producing toxins A and B, leading to colitis. And the spore form, the spores released. It can live in the open environment for several months to years. Very difficult to kill. So the vegetative form is susceptible to those wipes that you use. They'll kill the vegetative form, but they'll die on a countertop anyways. They're anaerobic. They can live on moist surfaces for up to 6 hours. Again, the vegetative form produces the toxins. They are susceptible to your gastric acid, hydrochloric acid, to antimicrobial soaps, and they're also susceptible to alcohol-based hand sanitizer. It's the spore form that we really need to be concerned about, as you heard the experts talk about earlier, because they survive for a long, long time on just about every surface known to man. They're resistant to gastric acid, so when you swallow them, your stomach acids will not kill them. They're resistant to the soaps you use, and they're resistant to hand sanitizers. And given the right conditions, they will rapidly change to the vegetative form and they germinate. So how is this infection transmitted? Let's take a look. We ingest a spore. Maybe we touch a dirty handle, a doorknob, or a dirty counter. As we'll see, we might even have our own business office in our practice contaminated. And we swallow the spores and they reach the stomach, and the gastric acids do not kill them, and they continue on to the small intestine. When they reach the small intestine, there is a primary bile acid exposure, the gallbladder, right? And this bile acid exposure from the gallbladder causes the C. diff spores to germinate. And there's quite a bit of research in how can we change the bile acid of somebody taking antibiotics, for instance, so that they don't cause this germination process to occur. So those spores will rapidly germinate into vegetative cells, where those vegetative cells travel to the large intestine, the colon. This is where colonization takes place. The toxins are produced and acute colitis occurs. So remember that the oral microbiome and the gut microbiome, today we're talking about the gut microbiome. This is the colon's specialized defense system. The gut microbiome is this community of bacteria, viruses, fungi, amoeba, slime molds, archaea, protozoans. It's ancient. It's this ancient community. And there are communities and subclades and sub-communities, and they have these various physiologic functions. It's very, very complex. It's very intricate. And one single dose of antibiotics can disrupt that and lead to a C. diff infection. And it does not have to be clindamycin. Okay, so keep that in mind as we talk here. So colonization resistance is disrupted when antibiotics are introduced. This allows the C. difficile to proliferate, produce toxins, and causes symptoms. So again, recap, how does transmission of C. diff occur? We disrupt colonization resistance, usually by antibiotics, but it can be other situations, as we'll see. We ingest a spore or spores in a contaminated environment. Colonization resistance disruption in the presence of a carrier is about 0.4 to 15% of the general population. So antibiotic stewardship and effective infection control measures are required to reduce the cases of C. difficile. Now, antibiotics save life. So we know that in many of our patients, antibiotics are required, but we're going to see a study about 80% of our prescribing practices are not required. Now, the percentage here, this 15% also may be elderly, older adults, inpatient, in an inpatient hospital stay, or residency in a long-term care facility. So there are risk factors for this 15%, or someone like me that's had C. difficile in the past. Carriers, again, can be asymptomatic, and they can spread the germs to others who may develop a serious infection. Those infected can shed C. diff spores for at least 5 months or more, and they can infect others who may develop a serious infection. Now, when I had my first hospitalization, the periodontist, I called them because you could throw a rock and hit their office. I wanted them to know that I had C. difficile, because if I was a clinician, I'd want to know if my patient had C. difficile. I'd want them to call me. I called him. He didn't call me back. He had his office manager call me. She said, "Oh, Dr. Rowling, we heard you're in the hospital with C. difficile. When are you expected to be discharged?" I said, "Well, actually, they're going to discharge me tomorrow." She said, "Great. Well, doctor would like to know if you're going to keep your cleaning appointment for Friday." I said, "No, I'm not going to keep my cleaning appointment for Friday. No can do, Lisa, not going to happen." I said, "Because A, I am contagious. You do not want me in your dental practice." She said, "Well, we don't have to give you antibiotics." And that was when the alarm went off for me. You know what? Many of us, we just don't get this thing. The last person you want in your dental practice is someone with a C. diff case, regardless if you're not going to give them antibiotics or not. And hopefully I'll impress upon you through this presentation today why. Secondly, I had to use the bathroom all the time. I mean, it was better, but none of it made sense, right? So never heard from that periodontist until August after. And I had the fecal transplant. They called me again. "Are you going to be able to reschedule your cleaning appointment?" I said, "Well, I was entered into a clinical trial. I had a fecal microbiome transplant." She said, "Oh, well, what's that?" I said, "Well, could you have, the doctor give me a call and we'll discuss. I need to know what the treatment plan is going to be, because if I have to take antibiotics for an implant, I don't want the implant. I can't take antibiotics." She said, "Okay, well, I've never heard of that, but I'll let him know." And she said, "So you aren't going to reschedule?" I said, "No, I'm not supposed to be in a healthcare practice for a while if I don't need to be." She said, "Okay." A week later, I got a dismissal letter from that practice stating that because I was not a good patient and I didn't return for my cleaning, and periodontal disease is a disease you can't cure, even though I was told I didn't have periodontal disease, I didn't have an infection, it was a template they sent me. "We don't want you here. So we're going to send you somewhere else. Let us know where we're going to send your records." And that was it. No communication with the clinician at all. Zero. And I will tell you, one of the things that gave me hope through this practice was that I was able to find this colorectal surgeon in Scottsdale who was performing the procedures and knew what C. difficile was. And one of the things he said to me that really impressed upon me, he said, "Kirsten, tell your dentist this. You don't need to prescribe antibiotics to prevent an infection because the science doesn't prove it. But also we have this thing called an immune system." He said, "Look, I perform hemorrhoid surgeries. A good part of my day, that's what I do. And I've never prescribed antibiotics to prevent an infection after hemorrhoid surgery. And he said, and that's just as dirty as the mouth. So if your playbook is dental practice management from the 1970s, I don't recommend it. I recommend you give your patient a little hope, contact them, see how they're doing, even send some chicken broth to their house would have been great. But dismissing them for not returning for a cleaning appointment was just, it was pretty disappointing to me. All right, so symptoms very quickly here. Bloody, watery diarrhea 3 or more times a day, cramping and tenderness, that would be mild. But the moderate to severe symptoms here, very frequent watery diarrhea 10 to 15 times a day, tachycardia, dehydration, fever, nausea, increased neutrophil count, kidney failure in severe cases, blood or pus in the stool. All of this I had. And life-threatening complications, ileus and toxic megacolon. So ileus is paralysis of the small bowel, which is probably what I had early on, and that's when I was feeling better. Toxic megacolon occurs when someone usually occurs from taking an antidiarrheal. So the colon, because when you take an antidiarrheal and you slow or halt the motility of the gut, these toxins have nowhere to go. So the colon swells up like a balloon and it will explode. It'll perforate. And that will usually be an event that the patient does not survive. Okay. So this is fulminant, C. difficile. They're looking down into the colon. This is a toxic megacolon case. You can see the radiolucency. This colon here is about 12 inches in diameter. And here's one that was removed. So you can see this is a life-threatening complication, which is why you never want to tell your patient to take an antidiarrheal if they develop diarrhea from taking an antibiotic. They should rule out C. difficile first. Who's affected? Anyone but the following populations: anyone taking antibiotics, proton pump inhibitors, immunosuppressive medications, anyone admitted to the hospital or a nursing home resident, over the age of 65, greater risk for severe illness, hospitalization, and death. About 1 in 10 will die of C. difficile. Female, for whatever reason, that hasn't been figured out yet. Those that are immunocompromised, cancer patients, HIV, and anyone with a prior C. diff infection. Why do we need to care? 500,000 initial cases every year. 30,000 die, 15% in the first 30 days. Recurrent CDI, 20 to 30% with at least one recurrence. Hospital cost annually in the US, $5.9 billion. C. diff data here, around 500,000 infections are caused by C. diff every year. As we said, 1/3 are likely to get it again. And after the first recurrence, 6 in 10 are likely to get another C. diff infection. And 8 in 10 with recurrent C. diff were hospitalized in 12 months and at least 3 separate times. The prevalence of C. difficile infection is increasing, I said, in outpatient settings, and this is one of those studies that discuss this, where hospitals are seeing a reduction. And the CDC has classified C. difficile as one of the 4 top antimicrobial urgent threats with the greatest number of deaths and the second greatest number of cases, and yet it is not nationally notifiable. So they don't track these cases in other settings outside of hospitals or nursing homes. Now, many of you are probably wondering, well, if I can't prescribe clindamycin, what can I prescribe? We're going to give you resources. Before we do that, I'm going to play a quick video. This is Christina's story. This is from the Peggy Lillis Foundation. They are a nonprofit. Peggy Lillis is the namesake of someone's mother who died following an extraction, and that case was clindamycin as well.
My name is Christina. I'm from Columbia, Missouri. C. diff for me started in 2012 from the overuse of antibiotics as a preventative measure for a root canal. Within a week, I knew that things were very, very wrong and was quickly put in the hospital and diagnosed with C. diff, which I had never heard of before. I was about to be married, so I wanted to be planning my wedding during that time, but instead, the next 7 months, I was in and out of the hospital 6 times. I missed 7 months of work, and I was growing gravely ill and dying. I barely made it out of the hospital in time to attend my own wedding, and my honeymoon was instead spent in the geriatric ward, too weak to even stand. All the antibiotic treatments failed me, so I resorted to the FMT, which is the fecal transplant, and that ended up saving my life. Fast forward about 3 years, I had a 2-year-old little girl named Pearl. I was 9 months pregnant with our son, and my daughter became violently ill. And I never gave her antibiotics. So it was my horror when she was hospitalized and diagnosed with a C. diff infection. And I watched her endure the pain, the fear, the sickness, the isolation, and for a 2-year-old, that's very scary. I realized that, the body is a lot stronger than I've been giving it credit, and it's been 5 years and I have not needed any antibiotics. I've been able to fight on my own. I've become an advocate because this disease is growing and it is increasing, and it is affecting the young and old alike. The Peggy Lillis Foundation has been very supportive and accessible. There's a network of people, and I feel like collectively we all have the same goal. I have a new fire in my belly now, and that is to make sure that this disease is stopped.
So her daughter, by the way, did survive that infection. I know a lot of people ask that because she sort of talks in pretense or past tense, but it's again a situation where there is contamination that occurs, and that's probably what happened there. And those spores live for a long time. They're very stubborn. This is an article for you, a link, and Dr. Tom Palmer is one of the co-authors who is a presenter on our course offerings and antibiotics. So he's the co-author of that. And again, I would urge you, and we'll give you the information for that, to take a look at that course. Outpatient antibiotic prescribing by general dentists in the US from 2018 to 2022. And we found after some education and after a bit of time, they went back in and looked, and the prescribing practices didn't change a whole lot, which was a concern here. So females, patients 65 years and older, and patients in the Northeast receive the most antibiotic prescriptions, by the way. So the prescribing remained stable from 2018 through 2022, despite guideline recommendations to limit antibiotic use for dental infections. All right, this is Dr. Palmer's course coming up in March. It's also available on demand right now. And if you take the live course, if you sign up before March 20th, he's giving 15% off. So if you need an update, this is the man, and he will be your friend for life, which is good to know. If you have a case and you need to run it by him, you can call him, you can email him, and he's going to respond. And then he also presents other courses on antibiotics and opioids. So there's the link. All right, dentist prescribers and CDI risk. We are estimated to prescribe 10% of outpatient antibiotics. That doesn't sound like a lot, but it's about 24 million prescriptions. Now, among the antibiotics that are commonly prescribed, some, of course, carry a higher risk. The highest risk is clindamycin, 14%, followed by the cephalosporins and the fluoroquinolones, like Cipro, Levaquin. Study finds 81% of dental antibiotic prescribing not needed. They looked at 168,000 dental visits from 2011 to 2015. And they found that fewer than 1/5 of those prescriptions were required because the patient did not have a heart condition, placing them at the highest risk of an adverse outcome from infective endocarditis. So this is significant because the most frequently prescribed antibiotic, of course, was amoxicillin, followed by clindamycin, the second most frequently. And this is a concern, right? Because clindamycin is associated with the highest risk of C. difficile infection, and dentists are the highest prescribers of clindamycin outside of a hospital setting. Now, 2017 study conducted in Minnesota found that 15% of patients diagnosed as having community-associated C. difficile, meaning outpatient setting, had been prescribed an antibiotic by a dentist, and at least half of those prescriptions were for clindamycin. The rationale here, per Dr. Suda, who's the lead author, she was at the University of Pittsburgh, I believe, is that all medical providers face some pressure from patients to prescribe antibiotics, but dentists are in a unique situation because they may also receive pressure to prescribe from other clinicians. So the Minnesota Department of Health tracked community-associated C. diff infections, and during a 6-year period, they determined that 15% of those with the infection who had taken antibiotics had taken them prescribed for dental procedures. However, 1/3 made no mention of receiving a dental procedure-related antibiotic. So it is important that when we consent to our patient, or we provide our patient with consent, informed consent for antibiotics, that we mention C. difficile and what they should look for, because this leads to a delay in diagnosis. For me, even when I told the physicians I had taken clindamycin, there was still a delay, right? There was a misdiagnosis. But patients should be aware. If they develop diarrhea when they take your antibiotic, they should not take an antidiarrheal, and they need to call you. They need to call you so that you are informed and you can make the decision whether they should be referred back to their primary care physician. So 36% of dentists prescribed antibiotics in situations that were generally not recommended by the American Dental Association, and of course, reporting challenges to making appropriate antibiotic prescribing. Now, if you are a practice where you're having your front office call a specialist, or you're having your hygienist or assistant calling a specialist, and the specialist's office is saying, yeah, we want that patient with a knee replacement to take clindamycin, and then you are going to the back to your bulk container and handing them a Dixie cup of clindamycin, that is a real concern, because your front office, your assistant, and your hygienist do not have standing orders from your specialist. They often, in most states, can't work under the supervision of an orthopedic surgeon. Your patient may not be getting the consent required, really, to understand what this antibiotic is. And you will hear Dr. Palmier talk about this, what you can do to protect your liability, protect the patient, inform the patient, and hopefully reduce the risk. Again, dentists write more than 24.5 million prescriptions. As healthcare workers working in a contaminated environment, when we take an antibiotic, we're at greater risk for developing C. difficile. So before you freak out, the best thing to do is wash your hands frequently, like you should be, and using a disinfectant that will kill the C. difficile spores. Also, again, the ADA, as a reminder, no longer recommends the antibiotic clindamycin for dental prophylaxis or therapeutic use, including cardiac or joint replacement indications. And this is the boxed warning that you see for Clostridium or for clindamycin. Your patients do not see that warning. Couple of legal cases here. I'm going to go right to the number 2 one. This was a 35-year-old father who had a non-vital tooth that was endo-treated, had reinfected, needed a retreat, went to his dentist of 10 years. The dentist prescribed clindamycin because he was told in a study club that he belonged to, but that was the choice, to quiet quote a non-vital tooth. Prescribed clindamycin to the patient. The patient developed a GI distress, called the office. The dentist prescribed Lamodal as an antidiarrheal, and the patient died a few days later in the hospital with toxic megacolon due to C. diff infection. The jury in this case ruled in favor of the family. Why? Because the dentist stated, well, this is what I learned at a study club. But they said the study club was not in alignment with the ADA recommendations. All right. A recent study in the UK suggested even a single dose of clindamycin may cause complications, including Clostridium difficile. We know that clindamycin may cause more frequent and severe reactions than other antibiotics. And it's no longer suggested. This was another study. Dumiati et al. Reported that 69% of patients with community-associated C. diff infections outpatient had received care at an outpatient physician office in the 12 weeks before the diagnosis, and 83% had received outpatient care when dental offices and emergency department visits were included. Nearly 1/3 had no documented prior antimicrobial exposure, which is interesting. 1/3 of those patients had not taken antibiotics. Now, this is a comparison of the different antibiotics, and you have this document in your course folder. But what I want you to understand here is that if you are not sure if your patient needs the antibiotics, so you're looking for one that would be appropriate with, quote, the low risk, that is not a recommended strategy, because any of those antibiotics can cause a C. difficile infection, any of them, amoxicillin even, doxycycline, minocycline, even in eye drop forms post-cataract surgery have been known to trigger a C. diff infection. So we have to make sure the patient needs the antibiotic. And even when they do need the antibiotic, C. difficile is a very real adverse event that can happen. But if we're not prescribing within the guidelines and we're subjecting more patients to antibiotics than need to be, we're adding to the number of cases, right? So again, how long can it take for a patient prescribing antibiotics to become symptomatic? It can be up to 3 months after they completed the antibiotic. The American Dental Association and the Infectious Diseases Society of America, probiotics not recommended to prevent C. diff. I will tell you, I've been told never to take an probiotic again, and not to take an antibiotic because of the fecal transplant, because they're worried that I would disrupt the gut microbiome, what's already worked for me, right? This new microbiome that somebody donated to me, we don't want to disrupt it with probiotics. So, but I was told there are other studies out there that may be better than the one that the ADA cites as well. Hospitals will often recommend probiotics and use probiotics to patients. And if you are one that you would like to refer probiotics to your patients, just make sure they leave a 4-hour time difference between the time they take the antibiotic and the time that they take the probiotic. Can we prevent C. difficile infection when antibiotics are prescribed? Well, the only way we can prevent a C. diff infection would be not to prescribe the antibiotic, but that's not always the case. Sometimes patients need the antibiotic. And again, there are ways that we can use antibiotic stewardship and infection control to reduce the incidence. These are the C. diff estimates for antibiotic resistant related infections. So mine ended up, it was a superbug. And there are 12,800 of those 30,000 deaths a year are due to antibiotic resistant related infections, which is the other reason we want to prescribe in a way that is in alignment, so that we don't lead these patients into having superbug infections. Also, determine if your patient's truly penicillin allergic. They can be tested for that. Here are resources here, evidence-based guidelines for prophylaxis and antibiotic stewardship. And again, Dr. Palmier is the co-author of many of these. Infection control, very quickly as we close here. I teach a course once a month, 3.5 hours on infection control. And it's important that you are mitigating for everything, of course. You're probably using a disinfectant that is on EPA list N, which includes COVID-19 or SARS-CoV-2. But we really urge you to consider using something to mitigate for these spores. And many of you are not going to want to use sodium hypochlorite because it's going to bleach things in your office. So hypochlorous acid is the way to go. And the companies that make a product that is neutral, that will not fade your carpeting, because you can spray it on carpeting, you can spray it on upholstery, you can spray it on electronics. That company is called Earth Safe or EvaClean. This is the comparison of antibiotic counts of antibiotic exposure and the adjusted odds ratio. So again, you can see clindamycin, which is a lincosamide, has an unadjusted odds ratio of 22.64. If you go down to like the tetracyclines, minocycline 0.97, that's Arestin. Doxycycline 1.61. So C. difficile, highly contagious, very difficult to kill. And this was a study that showed even the provider's work area in these different clinic sites was contaminated with C. difficile spores. We did go through that survey there. There's list K for you. If you leave here today and go to Amazon and purchase any old hypochlorous acid off of Amazon, it may not be correct in the concentration, and it may be acidic, which can cause problems for your units. Quaternary ammonium compounds, this is cavicide, a chemical class of emerging concern. That document is in your course folder. It was found that many of these disinfectant microfiber wipes actually cause more cross-contamination of C. diff spores because you are spreading them around. They're not killing them. You're just picking them up from one surface and taking them somewhere else. And another study showing the efficacy of hypochlorous acid versus the quaternary ammonium compounds. Can C. diff spores be aerosolized? Yes, flushing a toilet can aerosolize C. diff spores. Again, effective hand hygiene is required, and that's a course that we have available now on demand. Warning about bulk soap dispensers. If you're using something like this, they actually have biofilm growing in them. About 1 in 4 are contaminated, and they're often contaminated with fecal bacteria, norovirus, C. difficile, etc. So go to a system that is touchless, that looks like that, and you'll be safe. Other videos on hand hygiene, hypochlorous acid. Again, update your infection control protocol. We go into a much deeper dive on our website. Free to you all, 3.5 CE credits. How is C. difficile treated? As I said, there are antibiotics out there. Fidaxomicin is now the #1. Hugely expensive and not covered by many insurance companies. Second would be oral vancomycin. Metronidazole only used in areas where they're worried about cost containment, like nursing homes, unfortunately. Fecal transplant, little information here. The donor Open Biome no longer is providing these because they have medications that were recently approved. So the live biotherapeutic now can be ingested by capsule. It can also be used via enema. So I was in under deep sedation. It can now be an outpatient service called VOWST. Those are the capsules. Ribota is the others. There was a toxoid, Zinplava. It did not work for me, unfortunately, and it was used especially if you need to have an antibiotic and to try to prevent recurrent infection, but it's no longer offered. Here are some just anecdotal stories that people had posted on various forums. This is in Reddit. Fathers with C. diff, 36-year-old, got amoxicillin for wisdom teeth removal. Should I quit taking it? Just different stories here. Can we make an impact? It begins with, of course, our educational training. It's no longer just a board question that we need to pass. Antibiotic stewardship, review and implement the ADA's evidence-based guidelines, infection prevention to mitigate C. diff in our practices. Only bleach and hypochlorous acid are bleach products. Hypochlorous acid is non-toxic. It's in the hypochlorite family. It's what gets sprayed on your produce in grocery stores when you hear the misters come on. Advocate for C. difficile awareness and educate your patients as well, and embrace other technologies and locally treat infection. Ask your patients if they've had a previous C. diff infection on the health history form. Here are the resources for you. Again, I want to thank you all for attending today. Hopefully you have some information you can take back to your practices. And again, take a look at Tom's course here on March the 27th. It's available on demand, and you'll have an advocate for life.